Okay. So again, we're going to talk about evaluation and management services, and we're doing an inpatient documentation review today. We're going to be going through some specific examples of inpatient documentation and then determining a level of service. Again, my name is Ellen Barra, and on the call with me today is Rachel Wood, one of my friends and colleagues on our team. The first thing that we have is our disclaimer. And as you're aware, if you've attended any of our events before, we do provide this with all of our events. Medicare rules do change often. And as you're aware, if you deal with evaluation and management services, the Medicare rules on these have been changing all over the place for the past couple of years. The information that we're providing you today is based on everything we know as of today. However, the CMS rules and regulations will always prevail. When you're asking questions, we will provide responses as best that we can based on the information you provide to us in your question. And you can use the chat function to provide questions. But Medicare rules and your documentation will determine the final coverage. And then the last bullet point there, CMS prohibits recording of the presentation for profit-making purposes. If you are doing screenshots or recording this presentation, we do ask you, we ask you to stop. We are recording this presentation. We will be posting it to our YouTube channel as an encore, and that should probably take place within the next week or so. It appears the examples in the presentations that we're going to go through, or in the documentation we're going to go through, were billed based on the medical decision making rather than time. If you're billing based on time, don't forget to count both the face-to-face and the non-face-to-face qualifying activities that you're providing to your patients. The inpatient or observation notes are separate from any notes generated in the ER. As we're going through this presentation and looking at this documentation, we have determined a level of service, the level of problems, level of data, level of risk, as based on what's in the documentation. However, if you receive a denial or you receive a down code, either from the CERT contractor or from our internal medical review or other medical review contractors that CMS has, you have the right to appeal. When you appeal, you want to be specific. Here is why we believe this piece of documentation supports this level of problem, or this level of data, or level of risk. Using general terminology such as, please review the attached documentation or something like that, that's not going to help you. We've already reviewed the documentation, and therefore we have made our decision. So point us in the right direction, what you want us to look at within your documentation that you believe supports what you had originally submitted to Medicare. So let's dive into then our documentation. So the first piece of documentation we have here, you see that the date of the evaluation and management was 10/7 of 2023. We have information on the slide about the reason for the visit, which is sepsis and colitis. And that's in fact in two different places there. We also have information on our physical exam. So we have alert, responsive, the patient under the ENT, the patient is intubated. Under the lungs, or the person doing the exam can hear the vent sounds themselves. The patient's abdomen is still distended, but they are stating that this is benign. We have information on our visit vitals on the right-hand side of your screen, and you can see that the respirations there are high at 27. Again, we have no remarkable fever or anything else like that with this patient. So look at this problem list. Now, there's a lot of stuff on here. And in fact, our next slide actually even has more information on there. So what we want to be looking at when you're looking at your problem list is, are these all of the things that this practitioner is actually treating on this date of service? You can see there are also some things that look very duplicative. We have diabetic neuropathy associated with type 1 diabetes, and then we have type 1 diabetes with diabetic autonomic neuropathy. We also have additional just neuropathy listed on there. There's lumbar pain listed. We have a closed fracture of the transverse process of lumbar vertebrae, and we have low back pain. So are these really different problems, number one? And then number two, are these really active problems that this practitioner is treating for this date of service? Now, obviously, within your medical records, there's certain history elements that your physicians and practitioners need in order to provide the best care for the patients. But what Medicare needs to see is, what are you treating today? What makes your encounter today medically necessary for this particular patient? And does the rest of your documentation, is it going to support this type of problem list that has been submitted? So if you look on the next page, we have even more problems that are listed there. If you had a chance to look at this, one of the things you'll notice is that sepsis is not listed anywhere. So where did this problem list come from? And how is this effective for the patient's treatment when what has been identified as what's actually going on with the patient is sepsis and colitis? So again, this looks like everything the patient has ever had. And so what we're looking for when we're evaluating documentation is specifically, what is this physician treating, physician or non-physician practitioner, what specifically are they treating on this particular day? The next thing that we have is lab results. You'll notice that there is information there on a culture result that was ordered on September 29th. Well, our date of service is October 7th, so that would not count toward tests that are ordered or reviewed. That information is already there, has already been counted with the service this provider did on 9/29. You'll notice also on here that we have several different lab tests that have been ordered, and we have the results of those. You can see their white blood count is listed as high, the hemoglobin is low, etc. All that information in there. The practitioner has documented in their medical record that they have reviewed the results. And in some cases, we have seen the results in the note, but we really don't have any information as to whether the practitioner has reviewed those results and has used those results in their medical decision making. So your best practice in your documentation is for your physicians and practitioners to identify that this information just isn't in the chart, but I have used this in the medical decision making that I've made for that patient. And then the next thing we have in the documentation is the continuation of a medication. You can see there the MERREM. This is a medication that is used for infections. And the protocol shows on there every 8 hours for the patient. So now we have a summary that the provider has given us. It talks about this is a 54-year-old patient referred for consultation for sepsis and colitis. It identifies some of the other things that are going on with that patient. But again, what we want to look at is this practitioner treating all of these? Especially when kind of given the note that we have, this could be an infectious disease practitioner. So are they really going to be treating that patient's chronic back pain? Something to think about. So we have a summary of the patient's stay of care. Patient was in pretty bad shape when they were seen in the ER on 9/28. Patient was identified as being septic. They identified that the patient could also have colitis. They had a white blood cell count of 1.7. Again, but that's from 9/28 when the patient was admitted. Excuse me, not for today's date of service. And then it lets you know also patient was transferred to the ICU and was intubated. So then we go with impressions next. We have an impression of septic shock, acute hypoxic respiratory therapy, identifies that the patient was intubated on September 29th. We have colitis listed here. However, you'll also notice that it identifies that findings were not consistent with, I can't pronounce that word, with that type of colitis. We have pneumococcal urine that's listed there. And then we have recommendations. Well, under our recommendations, it again tells us that the flexible sigmoidoscopy was not consistent with the colitis. They are identifying that the colon edema was likely from the white blood cell count. There's information in there on continue treating for the hospital-acquired pneumonia that the patient has. And then we have information that says continue nutrition and supportive care. We discuss the status with the patient and the ICU staff, and this service will continue to follow and advise. So what we have determined for this is that the 99231 procedure code is the more accurate procedure code. Now, there's nothing in this documentation that shows this is the first time that this particular practitioner saw the patient within the facility. So therefore, we are going with that subsequent procedure. We determined that the problem was moderate, the acute hypoxic respiratory failure. This is one acute problem with systemic conditions. The patient has that hospital-acquired pneumonia, and they are intubated because they're having trouble breathing. We listed the data as minimal. Now, you'll notice on that previous slide that we had several different lab tests that were mentioned there. However, all of those lab tests mentioned are part of the comprehensive metabolic panel, and this is one procedure code. It's the 80053. Therefore, we would count this as one unique test, not separate unique tests for all of the individual procedure codes. So category 1 for data, for a low data, requires at least 2 tests. We didn't have that. We only have the one, the comprehensive metabolic panel. Again, we would not count the culture since that was ordered and performed previously. The risk identified within the documentation is low. There's no information, really no information concerning the risk to that patient from the decisions that they're making today for that patient. What the provider has stated is continue nutrition and supportive care, will continue to follow and advise. Now, in kind of looking at this patient's condition, looking at what's going on with this patient, um, if the physician or practitioner had documented the risk to that patient from what we're deciding on doing today, and that risk indicated something higher, I think the rest of the documentation would have supported that. But based on the fact that the doctor did not identify really risk at all, and with the language that that practitioner is using within their documentation, we would also consider this low. So again, we went with the procedure code, the 99231. Now let's look at example number 2. Well, example number 2 is for the same patient. And again, we have basically kind of all the same information. This is a data service of 10/8. We have, again, the reason for the visit is sepsis and colitis. That kind of brings up a question: is the patient actually still septic? And do they really have colitis? From that original piece of documentation, it told us that the flexible sigmoidoscopy really did not show colitis. So then why are we using these two again? We have our vital signs that are listed there. We have no fever, we have no complaints, and the patient is no longer on the vent. Now, I want you to kind of notice something here. Patient is no longer on the vent. I'm going to show you that on another slide. But look at our lungs. We have coarse vent sounds. When we get to the other piece of documentation, you'll notice that the patient has been extubated prior to this visit. When you're looking, especially inpatient subsequent services, you want to be talking to your physicians and practitioners that they need to identify what's going on today for this encounter for this patient, not simply carrying over information from the original service or from what happened yesterday, but really what's going on with that patient today. Again, we have the same problem list for both this slide and the next one. And again, neither one of these problem lists mention the sepsis or the colitis. We have information here on the same one test that has been performed, ordered, and reviewed. And so the physician can count this one, but it's only counted as one. It is in that comprehensive metabolic panel. Again, we would not count the culture because that would have been counted when it was ordered and reviewed. We have the same medication that is listed. And it looks like this one, I think, is going to end either the 8th or the 9th. I think the documentation will show. So again, we have our same kind of information there under that brief summary. And then look at the impression. Septic shock has been resolved. So why on that previous slide then is it saying that the patient is septic, when this information is showing that that septic shock or the sepsis has been resolved? It is still showing that the patient is in acute hypoxic respiratory failure. For the colitis, again, it's telling us that the flexible sigmoidoscopy did not show that. We do still have the pneumonia. So then we go into the recommendations. And again, this is where it's showing where the patient has been successfully extubated and is holding. That particular language tells us that they're really kind of watching this and watching to make sure that that patient's breathing is going to hold without that intubation. We have, again, information the white blood cell count has decreased. They're going to continue the drug for today, and then they'll observe. And again, we have covered nutrition. The status has been discussed with the patient, and then the service will continue to follow and advise. So on this one, we really went the same way. We have our problem as moderate, which is that acute hypoxic respiratory failure. Again, the patient has been extubated, but they're holding. And by using that particular terminology, we are looking at that as they're going to be really watching that patient's oxygen levels and their breathing to make sure that that's still okay. The data, again, is simply one unique test rather than more than that. And the risk to the patient as documented is low. Again, that goes back to that language. We're going to continue nutrition. We're going to follow the patient. And that's really all that they're telling us. So example number 3, this is an example of a provider who has submitted a combination admit and discharge code. So we can see here that the patient was admitted to the hospital on the 19th and then discharged on the 20th. Well, the H&P, you can see, was performed on the 20th at 10:30 in the morning. We see a chief complaint of shortness of breath with exertion. Pulmonary, could be pulmonary embolism or pulmonary effusion, and possible COVID 1 month ago. And then we have that statement there, admission criteria, but it doesn't give us any minutes there, and it doesn't give us any time. The next thing that we have then is the history. And you can see here we've got an 82-year-old female. And as you're looking through this, I'm kind of envious of what she's able to do. It talks about her going out to her barn every day. I think she has either animals or does some type of dog rescue is listed there. So the patient has presented for shortness of breath. The dyspnea, patient has generalized weakness and can no longer walk to her barn without stopping to rest. The patient did call an ambulance yesterday. That would have been the 19th. The EMS administered a breathing treatment to that patient. Patient does admit to dizziness, cough, bilateral lower extremity edema, and fatigue. The patient received 3 units of blood in the emergency room as opposed to on this particular data service. It also provides us with some additional information. Patient is well known to this particular provider. Patient states that they are doing much better after receiving the blood and the Lasix. The severe palpitations have stopped. She's been ambulating without shortness of breath or lightheadedness, and she is eager for discharge. I find that last comment just kind of amusing. Her main complaint currently is how bad the ER food is. So then we go into the exam. The blood pressure is good, the oxygen level is good, the patient is in no acute distress. And then we go into data. The provider did review multiple lab tests. I did not include the entire list in the documentation in our slide deck. It was pretty long, and the way it was arranged within the documentation, it would have been very difficult to actually place on a slide. But they did review multiple lab results. And then we also have the information here about the chest x-ray that was reviewed. This was reviewed on, or was taken on 4/19, and this provider is telling us that he did this review on the 20th when he's doing the data service. The next thing that we have is the assessment and plan. You can see here that we have patient has systemic anemia, or I'm sorry, symptomatic anemia. The patient has declined a blood marrow biopsy in the past. The patient was given instructions to stop Eliquis, a particular drug. The patient has respiratory insufficiency. I'm sorry, respiratory insufficiency, but previous information really kind of showed that was resolved. So this is another situation that we have that are we saying the same thing, or is it a difficulty when we have two different pieces of information within the documentation itself? The patient shows that the general weakness is resolved, and the patient does have COPD. You'll notice that admission criteria is listed there. Again, no minutes are listed, no time is listed. So now we have the discharge instructions. So it tells us here that they have spent 50 minutes on the patient's care, involving any needed evaluation, preparation of discharge records, prescriptions, forms, coordination of care, etc. And then this was signed at 4:20 at 10:30 in the morning. So this piece of information is pretty good in the fact that it tells us exactly how much time that practitioner spent on taking care of the patient on that date of service on 4:20. Now, this was submitted to us as, like I said before, as an admit and discharge combination. Now, this is incorrect as the provider, based on this documentation, did not see the patient on the 19th. The documentation really kind of indicates that the patient was admitted by someone else. The documentation also does not show how long the patient was an inpatient. In order to use the admit and discharge procedure codes, the patient has to have been admitted more than 8 hours, and generally the admission and discharge will take place on the same day. As we talked about in our webinar on Tuesday, there is a situation where that can carry over to the second day, and you could use the admit and discharge combination codes. But in this documentation, it doesn't give us any of that information. So the provider, however, can submit the discharge management procedure code, the 99239, as long as they are acting on behalf of the attending physician. Now, our documentation that we received from this provider really doesn't address that. It doesn't tell us really about anything that happened on the 19th. So we don't know for sure whether or not it was another practitioner that that admitted them, although that's what the documentation really kind of looks like. And they don't have any information in here that that practitioner asked them to do the discharge. So if they're in the same group with the same specialty, then Medicare would go for that. We would allow them to do that discharge management. If it's another type of situation, you really want to have that documentation within the medical record itself. So now let's look at example number 4. On this one, we have our author type is a resident. And we can see on here that the resident signed this documentation on 4/11, and then the physician signed this documentation, excuse me, on 4/12. So we have our brief medical note here, and it looks like the resident is talking to this patient about surgery on the 12th. The resident discussed the treatment options, the risks, etc. with the patient. Now, the risks that are identified here seem to be the normal risks from this particular surgery, and that's good information to have in the note and to share with the patient. We would have liked to have seen, though, any specific risks to this particular patient, either because of additional diagnoses they may have, comorbidities that may be going on, etc. The patient expressed understanding and they want to proceed with the surgical procedure itself, and it identifies that the surgical consent was signed. Now, have you noticed what's missing yet on this? This note was done by the resident. There is no information either on your slide right now or in the documentation itself that identified that the teaching physician was present during the performance of this particular service. So this service is non-payable by Medicare. Medicare does not reimburse for services provided by a resident unless the documentation supports that teaching physician was present at the time of that service. So what we mean by that is that the teaching physician has to be right there when that resident is doing the key and critical portions of a service. Now, when we're talking about evaluation and management service, the problems, the data, the assessment of risk, all of those are the key and critical portions of that service. During the public health emergency and the waivers that were implemented during the PHE and the waivers that are still in place now, that teaching physician could have been available based on audio-video communication, meaning that that teaching physician, the audio-video equipment was in the room while that resident was providing those services to that patient. Now, the other way that Medicare can reimburse is that, well, let me go backwards a minute. So in the documentation, the resident can identify and document that the teaching physician was present. A nurse can document that, or the physician can document that. The other situation that we can have where we can reimburse a teaching physician for services that are actually done by the resident is under what is called the primary care exception. And under the primary care exception, these are generally outpatient services. And under that primary care exception, the resident is doing the service in the room, but then they're coming out and talking to that physician, that teaching physician, after seeing that patient. And then they're working together in order to provide that care. Well, what we have in this situation is we have an inpatient service. So the teaching physician guidelines would have to be in place, which means that teaching physician would have to be present while this service was actually happening. So the next thing that we're going to go through then are questions, and we received some pre-submitted questions, and I'm going to go through a couple of those prior to Rachel kind of opening up our chat. But one of the questions we received stated that an inpatient stay requires a daily note. If the specialist makes the note, does that specialist note count for the attending note? So I think there's kind of two different ways that we could go with this particular question. One has to do with your hospital requirements, all of their certifications and everything within Medicare. If the certification or the hospital policy rules indicate that a physician has to see that patient on a daily basis and has to enter information into the medical record, then if that is the question, then a specialist note would be a note within that patient's medical record for that day. However, the specialist note would not count as an attending note if that attending plans on submitting those charges to Medicare. In order for that attending to submit those charges to Medicare, they would actually have to be providing that care to that patient. And then, of course, that care would have to be medically necessary. Another question we received had to do with copy and paste. And this is an issue that we see quite often. And so the question came in is, how do we kind of look at that information? Well, we look at the entirety of the note. As we talked about in our Tuesday webinar, and this issue really kind of is a bigger deal with subsequent hospital visits, each of those notes have to stand alone, meaning that each individual note for every day that your physician or practitioner is seeing that patient in the hospital has to show exactly what's going on with that patient today and what services and what care is your physician or practitioner providing to that patient today. As we talked about in one of our examples, they kind of carried over that sepsis and colitis, even when another place in that same note for that day showed that that was actually resolved. What we're looking for is documentation that supports today's service. So if we're seeing documentation for an inpatient stay and every single day looks the very same and it is standard notes or it's copied and pasted from day one, that's going to give Medicare pause. Number one, if your patient is in the hospital for more than a couple of days, then things are probably resolving. Now, not always, obviously you're going to have patients who their problems are not resolving while they're in the hospital. But for most of your patients, as your physicians and practitioners are providing that care, the patient's condition is going to change and more than likely get better. That needs to be reflected within the notes. Simply to carry over that information from that first hospital day, that's not going to be acceptable with Medicare. So talk to your physicians and practitioners and let them know they need to document what did you do today and what care did you provide to that patient today. The next question that we have, and this question I'll just tell you kind of disturbs me a little bit, but the question says, can the hospitalist submit a procedure code to Medicare for reimbursement based on time, is what it said in the question, when what they have provided to that patient is simply a recap of all of what everybody else has provided to that patient on that day? Well, the answer to that would be no. What's the medical necessity for that hospitalist providing that recap? Those physicians and practitioners, the other physicians and practitioners who provided care to that patient, are responsible as part of that care that they're providing to be telling the patient and communicating with that patient as to what's going on, what they have planned, any information that that patient needs. Hospitalist let me put it this way. A hospitalist has to comply with all of the Medicare rules and regulations. So a hospitalist, their services also have to document the medical necessity of what they're providing to that patient. So for an example, if the patient is going into the hospital, let's say for a knee replacement or for some other type of illness or injury, and that's the only thing that's going on with that patient, they don't have any other problems or diagnoses or injuries or anything else, then there's no medical reason for the hospitalist when that specialist is treating that broken leg or the injury or illness or whatever else is going on with that patient. So it it has to show the medical necessity for what that hospitalist is doing and what care they are providing for that patient on that day. Medicare understands that there are a lot of hospitals that assign a hospitalist to patients when they come in, and every patient will have a hospitalist assigned to their care. But if there is not medical necessity for that, then Medicare will not make payment for that. That's simply an additional charge to the Medicare Trust Fund, and then it's an additional charge to that patient. So that's the pre-submitted questions that that I wanted to bring. So we'll go ahead and open it up. And Rachel, what questions do we have?
All right. So our first question, I'm just going to go up the list here. Our first question is, if the physician has initiated a new medication on day 1, and then on day 2 and 3, they say they are continuing to monitor for effectiveness, mood, and behavior response to that medication, would that count as medication management?
Okay, well, what you want to look at is that number one, under the risk category, an example of risk category is prescription drug management. Okay, for moderate, and then you have the parental services. Let me find my list here real quick. Under the high category, where'd it go? Parental controlled substances. So what you want to look at when you're choosing risk is, what does your physician or practitioner document about the risk to that patient from that medication? If you're doing an oral medication within a hospital setting, that's what we're talking about here today, then if that oral medication presents a risk to that patient, you want your physicians and practitioners to document that. And then, yes, you could use that information. What you want to keep in mind is that the examples that are listed under the risk category are just that. It doesn't mean you always count that category if you prescribe a medication for the patient. It's what is the risk to that patient from the treatment and the medical decision making that your physician or practitioner has determined for that patient. Next category or next question.
All right. As our next question is, I think, a little bit similar, and you may have already just answered this, but the question is, if a specialist starts a patient on an IV that requires intensive monitoring, can the attending hospitalist still count intensive monitoring when they monitor and document that during their round?
Okay, are they doing the intensive monitoring? It should be the physician or practitioner who ordered that. That's the okay, let me go this way on it. The practitioner who ordered that medication that is going to take that intensive monitoring, that's the practitioner who will identify the risk to that patient and then will be in charge of doing that intensive monitoring. When the hospitalist is treating that patient, They are not ordering that intensive monitoring. And unless the documentation is showing that that's being transferred in some way, that's not under what the hospitalist is doing. So no, the hospitalist would not count that. Again, that goes back to that medical necessity. That person who ordered it should be watching that monitoring. Next question.
All right, so our next few, I think, are some clarity on some of the documentation examples we went through.
Sure.
So this question is involving the culture that we went through in one of the examples. And the question is, if culture was ordered by another specialty, why aren't we counting this review by this? Why aren't we counting the review by this provider?
Because the documentation does not support that it was ordered by someone else. The questioner is exactly right. For that first data service, and just so everyone's on the same page, we're looking at example 1. The data service on that one, I think, was 10/7, and the culture was ordered on 9/29. If this physician had ordered that culture, and that's what it appears, it could be something different, but that's what it appears in the documentation. If they ordered it for their service on 9/29, that's when they would have counted that. If this had been ordered by someone else and the documentation had supported that, then yes, they could have counted that, and that could have moved that data up one. I think we had minimal, let me go back to my slide on that. I think we had minimal data on that one. And if that had been ordered by someone else, different group, different specialty, then yes, you could have counted that. Next question.
All right, so this one is about the example with the colitis. And so the question is, instead of discounting colitis altogether, wouldn't it be better to ask the provider about this if it's a different type of colitis, since they noted it was not pseudomembranous colitis?
Okay, and I'm glad you pronounced that word because I couldn't get my mouth around it earlier. And that's a very good point, and that's a very good question. When we're looking at example number 1, remember I told you that we have reason for the visit for both of the services. Example 1 and 2 says sepsis and colitis, but when we looked at that problem list, neither one of those were listed as the problem list. So when you're looking at the documentation to doing your coding, if there are questions, as I identified, it's indicating that the sigmoidoscopy did not support the colitis with the word that Rachel just said, did not support that. Okay, if I was the coder or biller, then yes, go back to that physician or practitioner. Okay, here's what you say, sepsis and colitis, but this part of the med record says no. So which one is really the information that you want us to look at, and you would, be willing to give to Medicare, to give to other reviewers, to lawyers, to, whatever. And do they need to do an addendum to their medical record documentation? And this type of situation really is more prevalent in the subsequent hospital visit services. Next question.
All right, so our next one is about some medications, and pardon me if I mispronounce this. Why did you discount the meropenem? Under a recommendation, the provider is still continuing to treat the HAP with this medication outlined through 10/8. That is a continuation of medication.
And you're right, it is a continuation of medication, but it doesn't identify any risk. So, and again, I cannot kind of emphasize this enough. Under that risk category, under that table or that grid that the AMA has put together, what's listed there is not automatic. You have to identify the risk to this patient from the medical decision making. So for an example, if with this particular medication, if the physician or practitioner had indicated the patient is at risk for heart trouble, or the patient is at risk for their blood pressure dropping out, or something along those lines, then we could have considered the risk a little higher. The fact that the patient is on this medication, the practitioner did not identify risk. I think what they said was simply continue nutrition and supportive care. They'll continue to follow and advise. If that's what's in the documentation, that's the only thing that we have to go on. Next question.
All right, this is the last question we have in the chat right now. So the question is, what do we need to see documented for a decision regarding hospitalization?
Okay, well, in the examples that we have, the patient has already, been hospitalized. Generally speaking, a decision for hospitalization itself would have come either through the ER or possibly through an office or other outpatient service. It could also come with the observation care. Let me find that information in the AMA document real quick. Okay, the other type of situation where you may have this is when you have a situation where you need to escalate care. And so what they're talking about in that situation is when you're moving possibly from normal E&M services, a patient is just in a normal bed, into making a determination about moving that patient to critical care services. Again, your documentation will have to show that the fact that you are making that decision, and obviously the medical record should show why you're kind of making that decision also. And then Medicare and other medical reviewers will consider that as as information showing the level of care that you have provided to that patient. Okay, Rachel, do we have any additional questions?
Yes. So follow up on that one. So the hospitalist can't use this when he or she is admitting from the ER, for example, having a conversation with the ER doctor.
Okay, and that's a situation that can happen quite often. What you have to determine, though, is who decided that the patient needed to be hospitalized. Now, in some cases, that ER physician is really determining that the patient needs to be hospitalized, but they may not have admitting privileges. So, but they're the ones who made that decision, and they're transferring that care to that hospitalist, who then is going to do that initial hospital service. In other cases, you could have where the ER physician is identifying that that's a possibility, but they're not documenting that they made that decision. Instead, the hospitalist is determining that they made the decision. So it all goes back to what does the documentation show as to who made the determination to actually admit that patient. This question kind of comes up quite often in office level services also. And the question that we get all the time is, we have determined that the patient needs to go to the ER. Can we count this as, or can we consider this as we determined the patient needed to be hospitalized? Not unless you're making the determination that the patient needs to be hospitalized. If you're sending them to the ER first, the question would be why. And then the second question would be, who's actually making the decision to uh, go inpatient? Next question.
All right. So let's see. Regarding the risk column and prescription drug management, it seems current guidance has changed from previous guidance, and seems that so the statement is, it seems that WPS will never give moderate credit for prescription drug management unless it is explicitly stated by the provider as moderate. Is this correct, and can you explain the change?
What we're going to be looking for within that documentation is the risk to the patient from the medical decision and the problems for that patient, and then the medical decision making that that physician or practitioner did. So prescription drug management is not an automatic moderate level. If you have a patient that came in today, you've been treating them for 6 years for hypertension, and you're renewing their hypertension medication, how risky is that for the patient? They've already been taking that medication for a long time. Therefore, it is not, unless there's something else going on, it's not a moderate risk. So one of the things that coders and billers need to move away from is that the information within that risk column is an automatic, because it is not. It is an example. So in your documentation, if you identify that your practitioner is renewing or ordering or keeping the same or changing, whatever the situation is, what is the risk to that patient from taking that prescription medications? And then your physician will identify that risk, and then Medicare can code from there. Just a prescription drug in and of itself, without any other additional information, we would not count that as moderate. So we want to thank you very much for your attendance today and the great questions that you have had. And this now concludes our presentation. Have a great day.